Hi guys, welcome back. The next topic we're studying is interstitial lung disease, where I shall be doing a clinico-pathological correlation and tell you regarding how to pick up this disease in history. Why that is important is because most of the time the manifestations of interstitial lung disease can be really subtle. So there would be some very fine aspects given in the history and examination that you need to pick up and understand the disease. But for that, we first need to understand what is the etiology behind it. So let's look at first the usual causes that we are aware of. So I would like to subdivide the discussion from the etiology domain into two, the known and the unknown causes. And well, the first and the most important reason would be occupational exposure, where my patient is working in a cement plant. Now you are aware that if somebody is working in construction business, then the disease that could be developing due to inhalation of especially asbestos fibers would be asbestosis, whereas my next patient is having the most common occupational lung disease of India, that is silicosis. You are aware of the fact that asbestosis per se would be mica industry or working in a cement plant or construction business per se. Silicosis would be glass, but I now want to make a very interesting observation, which is that coal workers pneumoconiosis is an occupational lung disease, but you will notice that neither in Robbins and neither in Harrison, coal workers pneumoconiosis is not included in the list of interstitial lung disease. That results in lots of students sending up this query that, sir, if asbestosis silicosis will cause pulmonary fibrosis, then what is the issue with coal workers pneumoconiosis? Well, I want you to understand that when you read the term coal workers pneumoconiosis, what is going in the lungs of the patient is carbon. Carbon per se irritates the alveolar macrophages and results in production of elastase. This elastase will act on the airways and will damage the walls, resulting in emphysema-like features. And you are very well aware that emphysema is an example of obstructive airway disorder, whereas interstitial lung disease per se will cause pulmonary fibrosis and is an example of restrictive lung disorder. So please remember the fact that coal workers pneumoconiosis per se is not included in the list of interstitial lung disease, and the carbon that I was talking about is the same that would be present in a burnt cigarette smoke as well. The carbon present in a burnt cigarette smoke and the tar that goes in the lung irritates the alveolar macrophages and again results in development of obstructive airway disorder. So exposure is one of the important ones. For the next one, I can give a clinical example before you. Let us imagine there's a patient of Hodgkin's lymphoma. He's having hilar lymphadenopathy, which is pressing on the superior vena cava, causing superior vena cava syndrome. Superior vena cava syndrome will cause extensive congestion of the face. There would be prominent neck veins in a person. In fact, the JVP column will not fall with respiration in this guy. Like in you and me, you are very well aware JVP falls with respiration, but in this case, it will remain permanently elevated. Well, in this person with superior vena cava syndrome, a therapeutic step that I'm taking is giving radiation to the chest. Now, the good news is radiation will obviously cause shrinkage of the size of the lymph nodes, and therefore the mass compression on the superior vena cava will reduce. But the bad news is, well, radiation can cause pulmonary fibrosis. In fact, it has been documented that radiation can even cause premature coronary artery disease. In fact, I can give another example. Let us say a lady is having recurrence of breast cancer. Even in that case, when there's a recurrence of breast cancer, you will have to give radiation to the chest. The good news is radiation will obviously destroy the cancerous cells, but at the same time, radiation to the chest per se can contribute to pulmonary fibrosis and a resulted restrictive lung disease slash interstitial lung disease developing in a patient. So I've given you two scenarios for radiation: Hodgkin's lymphoma producing a mass effect and a superior vena cava syndrome and recurrence of breast cancer. I will now introduce some drugs here. The first one is amiodarone. I have spoken about amiodarone twice prior to this discussion per se. One, I've taught you it is the drug of choice for ventricular tachycardia. Second, I've taught you it can cause both hypo and hyperthyroidism as well. So today I'm teaching you long-term usage of amiodarone as documented to cause interstitial lung disease. Then is gonna be the drug that we prefer in rheumatoid arthritis, that is methotrexate, and a urinary antiseptic by the name of nitrofurantoin. In fact, for nitrofurantoin, I also want to bring to your attention the fact that there is another radiological finding that can be seen, or I would say pulmonological involvement seen with nitrofurantoin usage is fleeting pulmonary opacities. These fleeting pulmonary opacities will be having a slightly different distribution as compared to that of miliary TB. And anyway, the fundamental difference is that in miliary TB, the white spots are gonna be permanently present till you actually treat the person. But as the name is suggesting, fleeting pulmonary opacities, they are tending to disappear per se. And you read about fleeting pulmonary opacities, or at least two examples that you should know is one with respect to worm infestation. When the worms are migrating through the lungs, you can get fleeting pulmonary opacities. Second is the urinary antiseptic, that is nitrofurantoin usage. So nitrofurantoin can cause two things. One is on the board and second would be restrictive lung disease. The third entry is important one from the exam domain because this is taught in pathology as well, connective tissue disorders. In fact, what are those connective tissue disorders that can be resulting in interstitial lung disease? It is rheumatoid arthritis, then is scleroderma, which is also called as systemic sclerosis, polymyositis, and dermatomyositis. For these three, where I put the dots, I want to highlight that the histopathological domain that is seen here is called as non-specific interstitial pneumonitis, whereas with rheumatoid arthritis, the lung involvement, the histopathological domain is called as UIP, that is usual interstitial pneumonitis. Guys, I have just solved a pathology question for you. It will say all except, the question will say all of the following lung diseases or all the following connective tissue disorders, because all of these diseases are involving the lungs as well. All of the following connective tissue disorders would be having a NSIP type of lung involvement, except the answer is RA, which will be having usual interstitial pneumonitis. The next entry that I'm making sounds very unfamiliar at the moment, that is vasculitis, because the thought process of ours is that vasculitis per se will cause damage to lung blood vessels and therefore hemoptysis will be a presentation. But the bottom line is, after all, there is a lung damage. The lung damage would result in pulmonary fibrosis manifestations. One of the important ones to be remembered by you is Wegener's granulomatosis, and the second one is Churg-Strauss. Wegener's granulomatosis is also called as GPA, granulomatosis with polyangiitis, and Churg-Strauss because it is having eosinophilia, asthma, sinusitis, allergies present. So it is written as eosinophilic granulomatosis with polyangiitis. In fact, these two topics are discussed right at the end of these lectures as well. So you can not only read about them in the vasculitis part that I've discussed in rheumatoid, but I've deliberately talked about these two topics even towards the end of this lecture per se, so that you are more comfortable with what was formerly called as Wegener's granulomatosis and Churg-Strauss. Well, these are the renamed versions of it. The last entry for the known causes that I want you to remember, and more so important for the exam, is granulomatous lesions that ultimately result in pulmonary fibrosis. One of them is very easy and everybody is able to relate to it, that sarcoidosis has non-caseating granulomas. So in the long run, there could be pulmonary fibrosis occurring in a patient. The next one I usually find people are relatively less able to relate to. That would be hypersensitivity pneumonitis, that is HP. In fact, I would like to add some therapeutic details of HP or important clinical details of HP at the moment as well. One, I want you to remember that hypersensitivity pneumonitis is an example of type 4 hypersensitivity reaction. This is, I have highlighted, though it's a pathological domain, because you see the older edition of Robbins used to say type 3, but the 20th edition of Harrison categorically mentions this as an example of type 4 hypersensitivity reaction per se. And now I'm going to jot down some of the important causes of hypersensitivity pneumonitis. So I would like to, one, make you remember that my patient is a farmer by profession and he walks into a barn. Now, barn is an area where they keep dried grass, that is hay, and on the surface of this hay there is a fungus, inhalation of which will initially cause acute manifestations of difficulty in breathing. There could be wheeze appreciated in the chest of this guy. The surprising thing I'm teaching you is that interstitial lung disease HP variant would be having an acute presentation. I mean, the normal thought process is interstitial lung disease will be having a long history, but you can have an acute presentation with exposure to this fungus, thermophilic actinomycetes, and that would contribute to bronchospasm. Yeah, you could have a subacute presentation, you'll have a chronic presentation where obviously pulmonary fibrosis will occur in the person, but I just wanted you to be sensitized to the fact that ILD in some scenarios can have an acute presentation as well. In fact, my next example will make you more comfortable with this than what you are at the moment. I'm talking about this guy who's working in a sugarcane mill. We're talking about a person who's suffering from bagasosis. Now, the point I want you to remember is that in bagasosis, obviously there is exposure to sugarcane dust. But again, the question asked is, what is the fungus that would be growing on sugarcane dust, inhalation of which will cause problems for the patient on an acute basis? That would be same thermophilic actinomycetes. Mark my words, they're not aspergillus, but thermophilic actinomycetes. My third patient is having Monday chest tightness. Well, Sunday is a holiday, right? On Monday, when he comes to work in a cotton mill, that is where he would be exposed to cotton dust and therefore he would be having difficulty in breathing. Per se, I want to highlight the fact that in bicyanosis, there is no fungus involved. I also highlighted there's a Monday chest tightness. Would you have a Tuesday or a Wednesday or a Thursday chest tightness, guys? Well, the answer is a yes, because suppose Sunday is a holiday When he will come to work on Monday, that is when occupational exposure will occur and symptoms will develop in a patient. When this person is not exposed to the antigenic stimulation of cotton dust fibers going in his lungs, the symptoms usually do not occur. This is totally different from asthma. You see, in asthma, if you have one exposure to allergen, bronchospasm starts and the illness will last for a few days. But in these patients, the symptoms develop whenever a person is having a antigenic exposure in the form of the data that I've given before you. And once the person is away from this for, let me say, a couple of days, weeks, etc., the symptoms of these patients will regress as well. But due to long-term insult to the lungs in hypersensitivity pneumonitis, that is HP, and there are three examples of HP that I've just discussed with you on this slide, there would be in the long run a development of pulmonary fibrosis. My objective was to sensitize you to the routine causes of interstitial lung disease with the important message Kohlwerker's pneumoconiosis is not included in this. And if you're reading this for first time without having refreshed the pathological component, so I can just give you a quick mnemonic so that you can remember the data. You can remember the mnemonic etc. VG. So etc. here would stand for exposure. I was talking about asbestosis, silicosis. Then is the therapeutic aspect. What I mean by therapeutic is you were giving radiation for benefit of the patient, but look what it has caused, pulmonary fibrosis. And in fact, radiation is also documented to cause premature coronary artery disease. One of the important aspects in etc. C would be connective tissue disorders, 4 of them, and then I've solved a histopathological question based on the discussion here. RA will be responsible for the UIP subtype, and the remaining 3 are for non-specific interstitial pneumonitis. V would stand for the vasculitis component, 2 of them, that is Churg-Strauss and Wegener's granulomatosis, and then is obviously the easier ones, granulomatous lesions like sarcoidosis, HP. I mean, I usually find people very easily being able to answer aspects of sarcoidosis and HP being responsible for pulmonary fibrosis in the long run. But you also need to remember the other ones which I've told in the decreasing order of importance. And most of the time, the questions that are asked on the topic of interstitial lung disease will be having at least 2 choices. I can be very sure from pathology, and the remaining 2 from the therapeutics or the clinical domain that I'm gonna speak to you after approximately 2 slides. So you need to actually integrate this topic with pathology per se, because etiology is important so that we can work out the clinical pointers in the question. And don't be surprised and do not be under impression that interstitial lung disease, some subtypes can be actually having an acute presentation as well. I mean, the normal thought process is, when I was your age, I used to think ILD is only chronic, but that is not the case, and you will become much more comfortable with the acute presentations as I describe furthermore causes before you and then discuss the history component. I shall now be explaining to you regarding unknown causes of interstitial lung disease that would be causing alveolitis as well as pulmonary fibrosis. The first and the foremost to be remembered from the exam perspective is also the most common subtype of the unknown causes per se, that is IPF, as the name is suggestive, idiopathic pulmonary fibrosis. Not only is this most common, but he will also ask you about the bad prognosis associated here. So usually you will notice that whenever I'm discussing interstitial lung disease, the word will be bad. So keep a look for the one where I will say good prognosis, because normally ILD is bad prognosis. We need to study a subtype that will come after a few seconds, which is the good, which is one having a good prognosis. The mortality rate for IPF can be as much as 50% over the next 5 years. Now I want you to remember a subtype called as NSIP, that is non-specific interstitial pneumonitis. This is going to be relatively more common in female patients and would be having a good prognosis. Well, this is important, as I just highlighted before you, or I just sensitized you to the fact that when you read the data of interstitial lung disease subtypes, you will usually see it is written male and it is written bad prognosis. But one where you will always note in written gender female and having a good prognosis is non-specific interstitial pneumonitis. In fact, the next one I can put up as a question to you guys. Can you tell me which kind of interstitial lung disease is seen with cigarette smokers? In fact, initially, the query of most doctors is that, sir, cigarette smoking causes obstructive airway disease. It causes COPD, no? It causes emphysema, chronic bronchitis. You are asking what interstitial lung disease is seen with smoking? Yes, guys, I'm asking about interstitial lung disease seen with cigarette smoking, and that's an important MCQ. It is DIP. In fact, you have to become comfortable with these terms from pathological domain as well. DIP would be called as desquamative interstitial pneumonitis, and the reason why it is asked so frequently in the exam is mainly because of association with cigarette smoking. In fact, I can put up another question to you here. Can you tell me, doctor, any other disease apart from the one that is on the board, DIP? Can you tell me another cause which is associated with cigarette smoking and causes interstitial lung disease? When you read the textbook, it will talk about what is written as RBILD, that is respiratory bronchiolitis. Do remember my words? Respiratory bronchiolitis, associated interstitial lung disease. Alphabet R is respiratory bronchiolitis. Interstitial lung disease is also associated with cigarette smoking. In fact, there are three lung disorders, and they have been very frequently asked whether it is the recently concluded INICT in the month of December or November, December, or if you are going to talk about the former AIMS and JIPMER exams, they always used to ask which interstitial lung disease is seen with cigarette smokers, and there are three of them. Two I've already told you, and by the time I will finish this list, you will be ready with the third one as well. And the question was a all except version, where the fourth option was sarcoidosis. Sarcoidosis I've already talked about, that is has no correlation with cigarette smoking per se. The terms very important for exam, DIP and RBILD are anywhere to be remembered. The next subtype to be remembered is called as COP, that would be cryptogenic organizing pneumonia. In fact, when we read it for first time, no, it looks a little surprising terminology, because on one hand he's using the term pneumonia, but because it is organizing pneumonia, which basically means that after the insult to the lung is over, like the pneumonia part has recovered, that is when subsequently there could be a pulmonary fibrosis. I mean, I want to highlight that in COVID-19 also, no, some patients in the long run are ending up with development of pulmonary fibrosis. So once the viral infection has healed per se, that is when subsequently this organizing pneumonia can develop in a patient. The next subtype is again important, because he will say which subtype of interstitial lung disease can mimic ARDS. Now, ARDS is a very severe onset and acute onset illness. Interstitial lung disease, the thought process of ours is it's going to be a subacute or a chronic illness. So let's see a subtype of interstitial lung disease which could be as fast developing as ARDS per se. So that would be called as acute interstitial pneumonitis. In fact, the term used by the examiner will be AIP. I want you to remember that this could be so fast it can mimic ARDS like presentation. Acute respiratory distress like presentation. ARDS, in fact, is discussed separately in the serial order in the pulmonology section itself, where you can read about the diagnostic criteria, PaO2 FiO2 ratio less than 100, and then I've classified it as mild, moderate, and severe as well. Now, when I was a student at your age, I used to read about this same term, but in a different way. I used to read the term Hammond-Rich syndrome, which is now rephrased as acute interstitial pneumonitis. Why I mentioned the older term is just to sensitize you to the fact that we have read about this Hammond term earlier also. Like if you read this term, Hammond crunch sign, right? That's an auscultatory finding, no? Hammond crunch sign is gonna be an auscultatory finding, as if somebody is walking on freshly fallen snow with leather boots on. Well, this is an auscultatory finding that you will encounter in patients of pneumomediastinum. Do remember my statement? Hammond crunch sign per se is an auscultatory finding. It is like somebody is walking on freshly fallen snow with heavy duty military grade leather boots, and then you are obviously not supposed to mix this up with what is called as Hammond sign. Hammond sign is a palpatory finding, right? You feel it under your fingers in a person having subcutaneous emphysema. Like you can be reading about Hammond sign with respect to Boerhaave syndrome, where there can be air leak, and this air leak can contribute to then subcutaneous emphysema, and even sometimes a pneumomediastinum as well. The learning point for us is Hammond-Rich syndrome is the older term for AIP, and then are two findings. One is auscultatory, one is palpatory, that is Hammond crunch and Hammond sign as well. The next cause to be remembered is called as LIP, that is lymphocytic interstitial pneumonitis. Now let us look at why is this particular term important from exam perspective, and you will always notice this to be a diagnosis of exclusion in an AIDS positive patient. Why it is important, guys? Because traditionally in an AIDS positive patient, if a person is having radiological features, you will obviously think in terms of pneumocystis jirovecii or even tuberculosis. What I am saying is that a AIDS positive patient has come to you with breathing difficulty. You initially thought it is community acquired pneumonia. You did a workup, but community acquired pneumonia per se is turning out to be negative. You thought it is tuberculosis. You thought it is pneumocystis jirovecii. You even thought it could be histoplasmosis. It could even be Mycobacterium avium intercellular. All the common lung infections which occur in AIDS positive patient have been ruled out by you by testing the bronchoalveolar lavage of the patient. but in spite of extensive workup, no infective cause has been found out, then the diagnosis to be kept as LIP. I repeat once again, lymphocytic interstitial pneumonitis is a diagnosis of exclusion in an AIDS positive patient. He was having bilateral infiltrates or faint infiltrates visible bilaterally in X-ray in a documented case who's AIDS positive. Now, CD4 count of the patient can be given as any. He deliberately wants you to think in terms of all these infections. But since you have performed bronchoalveolar lavage and you have tried to rule out all the common infections and still the radiological infiltrates are unexplained, then the answer should be given as LIP, lymphocytic interstitial pneumonitis. I shall now be explaining to you a relatively longish name of unknown cause of interstitial lung disease. In fact, it is called as lymphangioliomyomatosis. The importance of this condition, why we are discussing, is primarily because it will be associated with development of spontaneous pneumothorax. Now, the usual query is, sir, spontaneous pneumothorax is seen with COPD, rupture of bulla, agreed. But even LAM, lymphangioliomyomatosis, he will describe a female patient. That's the second time I'm talking about a female patient where ILD is common. Last time I spoke about non-specific interstitial pneumonitis. This lady was having progressive breathlessness and rather sometimes there are exacerbations as well. The HRCT of this lady is showing cystic changes, which is again very surprising because traditionally you anticipate that a person having interstitial lung disease will be having findings of fibrosis plus traction bronchiectasis, the image of which will be shown to you subsequently. The exacerbations are occurring, which is due to development of rupture of the cystic spaces and therefore a development of spontaneous pneumothorax. In fact, this is itself a question, which interstitial lung disease can cause spontaneous pneumothorax? So the answer is what I've written here before you. Prior to this, I've taught you two causes of smoking associated interstitial lung disease. The names are desquamative interstitial pneumonitis and then was RBILD, respiratory bronchiolitis interstitial lung disease. Now is coming up the third name, which is associated with cigarette smoking, and again very important, it is written as LCH. And in fact, you would be more comfortable with this condition because even in pathology you read about this condition which has Birbeck granules and a CD1A positivity. Yes, guys, you got it right. This condition that has geographical skull is called as Langerhans cells histiocytosis or LCH. This condition per se is associated with cigarette smoking again and can contribute to ILD manifestations. The last one is discussed separately. If you scroll down in the pulmonology section, I have talked about this condition separately because here if I would have talked about the condition that I'm writing at the moment, it would have actually taken us off the track. I'll just say a few important things. You are aware that surfactant is produced in the airways and then has to be cleared also. The problem in the disease that I've written, pulmonary alveolar proteinosis, is that surfactant is produced, but the clearance of that is defective. So surfactant keeps on accumulating in the airways, causes initially obstruction of the airways, and in the long run, a pulmonary fibrosis will develop. So pretty surprising information on the slide. I'll just summarize the facts once again, guys. Surprising because interstitial lung disease causing pneumothorax is gonna be lymphangioliomyomatosis. LCH is related to cigarette smoking, already a surprising fact, and then PAP is going to be having initially obstructive manifestations because alveoli and the airways are going to be plugged by the surfactant, and later on there's going to be pulmonary fibrosis which will result in obviously the disease manifestations. And I've highlighted these causes before you because most of the time in the exam, as I said, they would try to correlate this with pathology, so it's very important for you to read these causes and then approach the clinical domain part, which I'll start subsequently. I shall now be describing to you clinical features that can be encountered in a patient of interstitial lung disease, and age will definitely give you a bit of idea because if he's talking about a patient who's older than 60 years of age with the varying manifestations that I'll explain to you suggestive of ILD, then you need to think in terms of idiopathic pulmonary fibrosis. On the other hand, if you are talking about a patient who's relatively younger, then the diseases that could be thought in terms of description could be, let me say, if it's a female patient, connective tissue disorders are definitely a possibility like dermatomyositis, polymyositis, rheumatoid arthritis, scleroderma that I was talking about. Then sarcoidosis is also relatively common in younger patients. Lymphangioliomyomatosis is common. Then Langerhans cell histiocytosis again is common in younger individuals. So age will definitely help you in, I would say, eliminating a couple of differentials. When it comes to gender, I have already highlighted before you that connective tissue disorders are relatively more common in gender female, but listen to my next words with lot of caution. I'm not saying the fact that rheumatoid arthritis is more common in male patients. I'm saying rheumatoid arthritis plus lung involvement. Mark my words there. Rheumatoid arthritis plus lung involvement is more common in male patients, whereas with other connective tissue disorders with lung involvement, it is gender female that obviously will play a role. And then, in fact, even duration of manifestations will play a role as well. I've already sensitized you to the fact that this is going to be chronic presentation, but some of them can be having an acute presentation. One of them is acute interstitial pneumonitis, that is also written formerly as Hamann-Ritz syndrome. And well, this condition does respond to steroids, but because of the sudden manifestation, lots of time can be misdiagnosed. Then is hypersensitivity pneumonitis, where we were talking about a farmer going into a barn and developing exposure to thermophilic actinomycetes, or even granulomatous with polyangiitis, that is formerly vaginous granulomatosis, can be damaging blood vessels of the lungs and can have an acute presentation. Now let us look at why these patients would be coming to us. Here I was just talking about the initial information given. I mean, what should be your thought process? And the standard history will be initially very non-specific, because in lung disease, there has to be some pointers present for you to pick up the disease. So I'll tell you about the subtle hints here. He'll initially talk about this 60-year-old man, or let me say 30-40-year-old woman, complaining to you about shortness of breath and dry cough, which has been persisting not for weeks but for months altogether, and even routine workup of tuberculosis has been done, has turned out to be negative. In fact, in some questions, because he will talk about hemoptysis in an old man, you will be suddenly tempted to think in terms of lung cancer, and yes, you should be. In fact, I want to highlight that if he is talking about an old man who's having shortness of breath and the other symptoms that I've written, you definitely have to rule out one, cardiovascular causes, because you are familiar that in old age due to atherosclerosis, cardiac causes would come up. So I definitely want to rule out, or I don't want to miss out presentations of pulmonary edema due to etiologies like myocardial infarction or even unstable angina. But assuming that cardiovascular causes have been ruled out, obviously infections have to be ruled out. That could be COVID-19, that could be tuberculosis. If you have ruled out cardiovascular causes as well as infections, then you obviously have to rule out possibility of lung cancer in an individual as well, which will always have the word written cachexia. So I want you to remember that CVS causes infection, lung cancer have been ruled out, and that is when you have to think in terms of ILD. So when it comes to differential diagnosis per se, ILD comes much lower down in the order. When it comes to hemoptysis, which interstitial lung diseases are nasty enough to contribute to this? One would be granulomatous with polyangiitis. GPA causes damage to blood vessels of the lungs and can cause cavities in the lungs, nodules in the lungs, and even a life-threatening hemoptysis in some cases. Even Lamb has documented hemoptysis, and then is Goodpasture. Now that's a surprising entry that I did not talk about earlier, because traditionally the presentation of Goodpasture syndrome is anti-basement membrane antibodies. Damage to basement membrane lung will cause hemoptysis. Damage to basement membrane kidney will contribute to the blood vessels of the kidney getting affected, contributing to hematuria. But Goodpasture syndrome in the long run again can have pulmonary fibrosis presentation. Then past medical history also plays a role, especially from evaluating Churg-Strauss syndrome, because Churg-Strauss syndrome is usually associated with asthma. So if he's talking about a patient who's now having shortness of breath, but in past medical history, there is a documentation of asthma in the person, then the disease that you are thinking in terms of is eosinophilic granulomatosis with polyangiitis, and eosinophilia along with this in the peripheral blood will also be present. Another one to be remembered, especially from past medical perspective, is I would say Raynaud's phenomenon if present. Like this lady, she says, doctor, whenever I used to put my hands in cold water, then the tips of my finger used to change color to white, then subsequently a bluish color will come, then subsequently a red color will come. So why am I thinking in terms of concomitant Raynaud's phenomenon is because Raynaud's can be seen in various connective tissue disorders, and all these connective tissue disorders that I enumerated can actually be having a lung involvement as well. Then comes the personal history related to smoking as well. I mean, if a person is a smoker, that is not a guarantee. In fact, that could be a ploy of the examiner that he wants you to deviate towards answering about obstructive airway disorders. But then the history that is present is going to be rather suggestive of DIP. In fact, I'll just mention the names once again in conjunction in a serial order, that is DIP, desquamative interstitial pneumonitis, respiratory bronchiolitis associated interstitial lung disease, and pulmonary Langenthal histiocytosis. Instead of writing LCH, he might write pulmonary Langenthal histiocytosis. They are the ones which can be associated with cigarette smoking, and obviously that is not a necessary rule. After that, what comes in importance would be occupational history of a person as well. Now let us look at what I mean by the importance of occupational history. Obviously, you can pick up routine stuff that I don't need to teach you. Asbestosis, silicosis, immediately you will pick up. But I also want you to pick up a rare presentation sometimes, because even if you talk about exposure to pigeons, right? The feathers of the pigeon, the fecal matter of the pigeon can be having antigens, the inhalation of which can actually contribute to a person developing pulmonary fibrosis in the long run. You see, when I say the word pigeon breeder's lung, it contributes to hypersensitivity pneumonitis, and HP, type 4 hypersensitivity, in the long run contributes to ILD in a person as well. So obviously asbestosis, silicosis is a piece of cake for you, never a big deal, but even this terminology, pigeon breeder lung, should be remembered. In fact, I've highlighted, right, in pigeon feces, Cryptococcus neoformans is also excreted, but if Cryptococcus will go in your and my lung, because we have good immunity, we'll kill it. Only in AIDS positive patients that the dissemination occurs from lungs to the brain and there's a cryptococcal meningitis. But then pigeon breeder's lung per se is an example of HP that can cause ILD manifestation subsequently. In fact, next I'll be talking about auscultation findings of these patients, and in fact this statement that I'm marking now before you, or I'm saying before you, is very characteristic and is usually written in questions of ILD. I have usually find this term very accurate for picking up ILD on clinical grounds. Obviously, in evidence-based medicine, I need to do imaging of the patient. Without that, I cannot confirm or I cannot comment on the diagnosis. But this terminology is very characteristic, that is end inspiratory fine crackles in the chest. You see, whenever we read about fine crackles, we always are thinking in terms of pulmonary edema as well. But here he's talking about a person who's having a long-standing history of shortness of breath with a dry cough. So, end expiratory fine crackles, or alternatively, he might use the word bibasilar crepitations. Both of these terms are relatively fairly accurate to pick up possibility of ILD in the question. In fact, in some questions to distract you, he can even talk about a wheeze. Now, how would that come up? That's because in sarcoidosis, you are aware that there can be a lymphadenopathy, and these lymph nodes will press on the airways, and therefore even wheeze could be present. In fact, these wheeze could be present at rest also, and will obviously not respond to bronchodilators in this case. Then, because there is a progressive lung damage, there would be cyanosis, oxygen saturation will fall, and when cyanosis starts developing, then later on, even clubbing manifestation will come. You can understand when he talks about clubbing in a person, you are tempted to think in terms of possibility of lung cancer, but then lung cancer will be having features like cachexia, features of Pankos tumor, there could be Horner syndrome manifestations given in a question, but in this one, it would be relatively, I would say, a bland question, talking about a person having a non-specific shortness of breath, maybe off and on hemoptysis, and then you started having cyanosis, clubbing as well, as the lungs are becoming shrunken. And whenever the lungs are affected, then after all, pulmonary artery hypertension cannot be far back. Once pulmonary artery hypertension will occur, cor pulmonale will occur. Cor pulmonale is the end result of all the lung diseases, whether obstructive or restrictive, because hypoxia will contribute to constriction of the pulmonary circulation, and therefore pulmonary artery hypertension will cause right ventricular failure. So the same patient can end up with development of pedal edema as well. In fact, if you look at the inferior data that I've written, especially if I just give markings here for these four, it could be any lung disease or it could even be a cardiovascular presentation. But the first one that I've highlighted, I'm now removing these markings from now. The first information that I've written, I personally find that that's a fairly accurate description of the lung process in this person, which will be having alveolitis and later on a pulmonary fibrosis. The area between the alveoli and the blood vessels is where the gas exchange of gas diffusion will occur. That gas diffusion will be hampered in this case and will explain the long-standing hypoxia. We obviously need to do an extensive workup of these patients. So let us now see what are the workups of these patients and how would you be able to confirm the diagnosis. The first and the foremost test to be done in the patient is to rule out connective tissue disorder. So I will be ordering an autoimmune panel in this person. You see, otherwise it is a very cumbersome process that you will write anti-nuclear antibody, double stranded DNA, and there are so many lists of antibodies that you can miss it. So when you write the word autoimmune panel, the laboratory person definitely knows the fact that the doctor wants to get all the routine connective tissue disorders ruled out. In fact, just to make you more comfortable with this, I can make you remember an antibody which can be easily forgotten by a busy practitioner by the name of anti-Jovan antibody. Guys, this antibody is encountered in dermatomyositis patients. Remember, dermatomyositis is condition where you read about Gottron papules on the knuckles. and heliotrope rash on the upper eyelid and a Scholl sign present and mechanics hands present, that same dermatomyositis with the proximal myopathy can be having interstitial lung disease association, and the antibody seen is called as anti-Jo1 antibody. So as I said, it's very cumbersome to remember the name of all of them. So whenever you write the word autoimmune panel, the technician will do these tests to actually help you in thinking in terms that yeah, the connective tissue disorder can be having a lung involvement as well. Now, when I do pulmonary function testing of these patients, I will be getting a restrictive pattern because there is a fibrosis. Total lung capacity will be reduced, and FeV1 FVC ratio. I have discussed about this even in the spirometry section. FeV1 FVC ratio can either be normal or even increased in restrictive airway disorder. Why? Because the denominator will be reduced in these cases. However, they can be obstructive pattern also. Which one of these would be having obstructive pattern present? Then one I can remind you having obstructive pattern is sarcoidosis. In fact, that's a very traditional question once again, that pulmonary function testing of which interstitial lung disease will be showing obstructive pattern. It is hilar lymphadenopathy or sarcoidosis that can explain the obstructive pattern developing. When I'll be running the chest x-ray on this patient, pulmonary fibrosis may not be so visible initially. So obviously he will talk about hilar lymphadenopathy if it is a sarcoidosis case, and sarcoidosis is again a separate topic that I've discussed in rheumatology, so you can go through that. But again, a very good hint in the question, if it is gonna be especially occupational like asbestosis, will be the word basilar reticular opacities. Guys, I want you to remember the fact that two terms which are beginning with B, which are highly accurate from clinical domain to identify this in an MCQ, is one, this terminology that I mentioned, bibasilar crepitations or end respiratory fine crackles at lung bases with a long standing history, because normally fine crackles are heard with pulmonary edema and that would be having a very short history. Second, I want to highlight that if you read the word basilar reticular opacities, that's again both are beginning with B, right? I'll show the slide once again. Bibasilar creps and basilar reticular opacities, fairly accurate description. In fact, in asbestosis, sometimes there might even be, an irregular involvement around the heart. So you will also read about this terminology, shaggy heart. Now, this is relatively non-specific finding, but yes, a irregular margin of the heart, shaggy heart, is documented with asbestosis. Moving ahead, the fourth investigation will help me in being very sure about my diagnosis, that is a HRCT. So I will show you images, but at the moment, let us just work out what is the HRCT finding, and I can then plan a biopsy for this patient. The best way to confirm the diagnosis is obviously a biopsy. But if he says what is the imaging modality that is recommended for these patients, then I'll prefer a HRCT to be done. That will be showing presence of subpleural reticular opacity. So you can see that these words like basilar reticular opacity, subpleural reticular opacities, and bibasilar crepitations are fairly accurate for diagnosis. The next terminology on HRCT will be that because of the fibrosis component, there will be a distortion of the normal anatomy of the airways. I repeat the fact once again, there is a distortion of the airways, not due to destructive process, but because of the fibrosis component that will change the routine ventilation, and therefore the term that I'm going to describe before you is called as traction bronchiectasis. I repeat the fact once again, when you read the word bronchiectasis, again the thought process is obstructive airway disorder due to destruction of the lung, infections. But here, as I highlighted, there is an airway distortion occurring due to pulmonary fibrosis, which will explain the traction bronchiectasis. If he writes the word honeycombing of the lung right away, this would be a piece of cake for you. So I've usually come across very few MCQs where honeycombing per se as a word was given, though this is very characteristic and would help you identify the disease. Another feature which is important from exam perspective, especially radiology, is what I want you to remember separately. You see, you will read about halo sign in a CT chest. This is read with a fungal infection, that is Aspergillus. In hypersensitivity pneumonitis, I was talking about thermophilic actinomycetes, but Aspergillus is discussed in the infection segment where there would be a lung cavity and an air crescent sign present. So halo sign is a very characteristic feature that you see with Aspergillus, and what I am teaching you here would be written as reverse halo sign. This radiological finding is seen with cryptogenic organizing pneumonia, that is COP subtype of it. Though as I have gone down the order in a like I've drawn an arrow here to just sensitize you to the fact that as I go down, the radiological findings will become very characteristic names, and these names rather help you in picking up the diagnosis. Like if I started by straight away saying, okay, HRCT chest of a guy with a long-standing breathlessness was having presence of honeycombing, so you know it is interstitial lung disease. So usually he will avoid writing the inferior terminologies. I have found most examiners asking about these two: traction bronchiectasis and subreticular opacities or subpleural reticular opacities. Those are fairly accurate terminologies. However, if he says what is the investigational choice for this condition, then I've already highlighted that I would like to go in for a biopsy in this patient. Now, to perform a biopsy, in earlier times they used to do a open surgical lung biopsy, but now we definitely have a bronchoscope available. So in fact, how would I do a biopsy in this case? I can do a fiber optic bronchoscopy. I already from the CT scan report know that which lung is mainly affected and which segments are the primarily ones affected. So I can do a fiber optic bronchoscopy in the patient and then perform a biopsy specimen, and the report will show the traditional information of pulmonary fibrosis and alveolitis. Investigation wise, you need to remember autoimmune panel first, followed by pulmonary function testing, followed by a chest x-ray and a CT scan, and then a biopsy that will confirm the diagnosis of this condition. Coming to the image-based scenario that can be given on this topic per se, he can give you a long-standing history of a cement plant worker who is currently suffering from breathing difficulty. When you looked at the X-ray, you noticed a shaggy and irregular appearance of the heart borders and lots of infiltrates in bilateral lung fields that could be mistakenly thought as that of pulmonary edema. But assuming that we have done a thorough workup of the patient, the cardiovascular causes have been ruled out, and then when we evaluated the patient using a high resolution CT chest, you definitely can notice these subpleural opacities. And in fact, one I would definitely like to highlight is this airways, which look relatively more dilated. So this image is actually showing one evidence of traction bronchiectasis in a person. I've highlighted bronchiectasis is what you traditionally associate with obstructive airway disease. In this case, the reason for bronchiectasis is distortion of the airway secondary to the fibrosis component, which is starting from the periphery. Let us now look at what is the treatment that can be offered to these patients, and the answer will depend on the etiology that is documented. If it is going to be IPF, idiopathic pulmonary fibrosis, considering the high incidence of mortality going up to 50% over next 5 years, we will be starting these patients of pirfenidone. In fact, you would have seen lot of COVID-19 patients who are persistently having oxygen requirement. They might be developing pulmonary fibrosis in the long run. So you would have seen lots of respiratory physicians starting patients of pirfenidone. Over and above this, we also have a monoclonal antibody. I mean, monoclonal antibodies are the answers that we have for lots of diseases as of now. So one more that is being added to your vocabulary is nintedanib. The first answer is pirfenidone for these patients. However, if in the MCQ is mentioning that the patient is a female and then there is a non-specific interstitial pneumonitis, then it is steroids. So be judicious in your answer. I mean, if it's going to be NSIP, it is steroids, but overall answer is not steroids, no, because 50% cases are going to be in the unknown variety of idiopathic pulmonary fibrosis. So it is pirfenidone that should be answered first. This is assuming that both are given in the question and he has not mentioned the subtype. Then I'm saying pirfenidone should be answered first. Prednisolone, then mycophenolate and rituximab are the drugs which can be used for non-specific interstitial pneumonitis. The prognosis is relatively better. For management of standard connective tissue disorders, obviously the usage of steroids will continue. Even certain cytotoxic agents can be used in this case. And if there's going to be a progressive lung deterioration, then lung transplantation is the only hope. And in fact, I can highlight towards the end of this discussion that if the question says that overall what is the most common cause of lung transplantation per se, then the answer will be the topic that we are studying, that is interstitial lung disease, and especially the subtype idiopathic pulmonary fibrosis. I repeat the statement once again. If he says what is overall the most common cause, why a person would be requiring a lung transplantation, the answer would be the topic we have studied in idiopathic pulmonary fibrosis, which was number 1 in the unknown causes per se. I would also like to spend a couple of minutes into describing two rare forms of vasculitis, which are anyway covered under the vasculitis section of rheumatology, but I just want you to be sensitized towards Wegener's granulomatosis, which is currently written as granulomatosis with polyangiitis. Well, the vasculitis will occur in upper respiratory tract. lower respiratory tract as well as the kidney, and that is where the classical manifestations will occur. If there is damage to blood vessels or the upper respiratory tract, there can be epistaxis in this person. If there is damage to blood vessels or the lower respiratory tract, there would be hemoptysis, and damage to the blood vessels of the kidney will contribute to hematuria. You see, combination of hemoptysis and hematuria is Goodpasture syndrome, but in this case, I've even included the upper respiratory tract infection here. And if the blood supply of any area is damaged, then there can be recurrent sinusitis also. It could be fairly severe. Additional bonus would be that if he gives you this classical terminology, strawberry gingiva, then you know that this is a feature of Wegener's granulomatosis reframed as granulomatosis with polyangiitis. If you do a HRCT chest in this person, the finding will be given as nodules. Then these nodules can break down to form cavities and ground glass opacities. In fact, this classical term, ground glass opacities, has become famous after COVID-19. But ground glass opacities can be found even in interstitial lung disease. I specifically use terms which were very classical of diagnosis. Subpleural reticular opacities is the important terminology that I want you to remember. But if I add to this discussion even the word GGO, ground glass opacities, that again helps you in identifying presence of interstitial lung disease. The next term that I'm describing before you is Churg-Strauss syndrome, which is called as eosinophilic granulomatosis with polyangiitis. The question will initially begin by describing features that might look identical to that of GPA only, but the additional facts what will be given, there will be history of asthma. When I was talking about GPA, there was no asthma associated, and I did not talk about any cell preponderance in the peripheral blood circulation. But in eosinophilic, as the name itself is suggestive, eosinophilic granulomatosis with polyangiitis, there would be a peripheral blood eosinophilia as well, and in these patients in the long run, subsequently, the fibrosis component would come in. You can read more about the subtypes of vasculitis like Henoch-Schönlein purpura, Kawasaki disease, even giant cell arteritis in the relevant section in RUMAT. But these two terms have been just highlighted to increase your comfort level. And in this topic, as I've highlighted right in the beginning, that if you are gonna just study the etiology per se, then you can automatically work up the workup of these patients as well. And the clinical history, if he begins himself by saying a cement plant worker having breathlessness, you anyway have cracked the question. I mean, there's no big deal, and unfortunately he's not going to give you an easy question like this. So lots of time he might actually give you a scenario of IPF that would be having features of shortness of breath, dry cough, hemoptysis, and that is where I want that if he's going to talk about maybe smoking association, if he's going to talk about hemoptysis, you might be tempted to think in terms of lung cancer also. That is where your skill comes in, that in lung cancer there should be cachexia, there should be features of Pancoast tumor, paraneoplastic manifestations given, and anyway final solution is with help of a CT as well as a bronchoscopy guided biopsy. And obviously if it's a lung cancer, that can be picked up both on a CT as well as a biopsy. We can take a tissue sample and we can identify which type of lung cancer is present. So the way the question's presentation is given, you would be able to definitely differentiate between the two. And tuberculosis is anyway out, because per se when you talk about tuberculosis occurring in a patient, then the age group of the patient will be relatively younger. In IPF, the age group would be relatively older, and even if in old age the TB manifestations are occurring, the symptoms would be over a couple of weeks, whereas in this case usually the symptoms would be going over months to years also. I mean, there's a possibility that person might have neglected his manifestations as well. So usual profile is that of chronic, but you also need to keep a watch on the acute presentation. Like if he begins by talking about a farmer or pigeon breeder's lung, as I was explaining to you, then these acute presentations are also to be remembered. If you get these initial two slides right, guys, I mean, that has been my experience with this topic, that when I was at your age, when I studied the etiology part well, that is when the subsequent part of the discussion became relatively easier for me. Otherwise it's a lot of information which can be mixed up with other disorders also. But if you get the etiology right, then I personally feel that you will be in a better position to score better on this topic. Thank you so much for hearing me out. Keep hammering, guys, keep learning and keep on upgrading your knowledge. As I highlight every time, knowledge is power. This is again a reminder to you that you need to continue pushing yourselves to the limit. Thank you so much once again.